Welcome, everyone, and thanks for joining today's webinar, an unwelcome cash flow strain on hospitals, 340B rebate model program impact. Before we begin, I'll walk us through a few quick housekeeping notes. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And if at any time you have issues with the audio or visual, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we're here to help. With that, I am pleased to turn the floor over to Allison Arendt, Senior Vice President of Client Development and Marketing at Clearway Health, to get us started.
Good morning and good afternoon, Sarah. Thank you for the introduction. On behalf of Clearway Health, welcome and thank you for joining today's webinar. I am Allison Arendt and have the great pleasure of working for Clearway Health and serving hospitals and health systems across the country and navigating specialty pharmacy services. And I am excited to be joined today by three panelists. We have Beth Feldpush from America's Essential Hospitals, Shannon Sale from Grady Health System, and Nicole Fauché from Clearway Health. And so without further ado, we're going to jump in and start talking about the impact and what to expect as we work towards a January timeline for this 340B rebate model pilot program. And so with that, let's get started. The first question is just to center us and really think about how have we gotten here? So over the last 12 months, what's happened and where are we now with the 340B rebate model pilot program? And Beth, we're going to start with you.
Great. Thank you, Allison, and welcome to everybody who's joining us. I'm delighted to be here today with this group. So I am going to start out and do a little bit of a brief history of the rebate pilot program, which is still new itself. But this all started around this time last year when Johnson & Johnson became the first pharmaceutical manufacturer to attempt to implement a rebate model for the 340B program. They were followed quickly by 4 other manufacturers, and really kind of set out to kind of change the rules of the road and really make what essentially is a sweeping change to the program. We responded very quickly at America's Essential Hospitals to this threat and pushed back against the pharmaceutical manufacturers, and also reached out to HRSA, the agency that oversees the 340B program, really, alerting them that we did not think the pharmaceutical manufacturers' actions were legal. HRSA agreed and responded and told the manufacturers that they could not unilaterally change the structure of the program, and asked them to cease or really not implement these rebate pilots. The manufacturers then turned around and sued the government and said, you don't have regulatory authority over this aspect of the program. And the fight kind of went back and forth in the court system for a little bit. We weighed in on behalf of the government, again, rejecting the manufacturers' attempts. And through the court system, I would say the judgments in general really held up HRSA's side of the argument that no, the manufacturers cannot do this unilaterally. But the courts, also kind of suggested that HRSA had maybe potentially overstepped its authority by rejecting them entirely without more context. So then in July of this summer, in response to those court cases, HRSA announced that they were going to be implementing this pilot program that would kind of test out these models, and they invited manufacturers to apply for that. So that happened over the summer. HRSA announced this in July. There was a pretty quick turnaround where really only until kind of the beginning of September did manufacturers have an opportunity to voice kind of how they wanted to do this, and stakeholders could weigh in as well. So we lobbied HRSA for more time. They did kind of give us another week to give them our comments on, how dangerous this would be for the program. And we kind of kept going from there. So forward then to kind of later this fall, there was HRSA responded They announced the approval of the first set of manufacturer applications in October. They were delayed a little bit with the government shutdown, but they did ultimately, announce these decisions. And I think what was surprising is, in limiting the program and saying that we're going to pilot this, HRSA said that they were only going to allow those manufacturers of that initial set of 10 drugs for which Medicare is negotiating prices. Only the manufacturers of those 10 drugs, and only those 10 drugs, would be able to be included in the pilot program. HRSA also put some parameters around the pilot program in its proposal, but we were surprised in October when HRSA announced that they had approved rebate pilots for then 8 manufacturers for 9 of those 10 drugs. They loosened some of their own rules that they had proposed. So, for example, HRSA is allowing manufacturers to collect additional claims information from hospitals and other covered entities. And while HRSA had initially said you can only collect data from these 11 readily available pharmacy claims field, the final announcement permitted manufacturers to require additional medical claims data as well. That announcement in October kind of further stated that all of the manufacturers have selected the same program administration software, which is the Beacon platform, to manage claims. And, I will say also that all of the manufacturers have included kind of every type of 340B covered entity in their plans. Now, what was absent from HRSA's guidance and notice in October is really kind of any sort of safeguards for how a potentially impactful and financially impactful program could and should be run. So, for example, if a hospital or community health center is concerned that they have maybe not gotten the rebate in a timely manner from a manufacturer, the only guidance HRSA gives you is to literally email the general inbox at HRSA, info@hrsa.com, and say, hey, we didn't get our rebate. So there's a lot around this pilot program that remains very much in question. And I would say, not ready for prime time, even as this is going to move forward in January. Manufacturers have been told that they need to give hospitals back these rebates within 10 days of a hospital submitting a claim. But again, there's no safeguard to ensure that manufacturers are upholding to that practice. So that is sort of where we are. We are launching toward this January implementation date. I will kind of further note that last manufacturer, Novartis, which had that 10th drug that's in the list, they did get their rebate pilot program approved after the other one. So theirs is now going to start in April of next year, while the others are beginning in January. But there's still a lot of unanswered questions. And I would say kind of hot off the presses, 2 things happened yesterday. We sent a letter to HRSA outlining in about 10 or 12 pages all of these questions that we have and that our member hospitals have for exactly how this is going to work and how HRSA is going to ensure program integrity on the part of pharmaceutical manufacturers. At the same day, the American Hospital Association filed a lawsuit attempting a temporary restraining order against HRSA for moving forward with that January 1 implementation date. So all of that is up in the air. And I will also say just one more thing before we move on. I mentioned briefly up front that there was litigation around this area. Even though HRSA is moving forward with this pilot program, and we think that implementation on that, again, will happen in the next few months, those court cases are also still ongoing. So at the very kind of merit of this question of does HRSA even have authority to implement a rebate pilot program, that is still up in the air as well. Like I said, the district's courts generally ruled in HRSA's favor. The manufacturers appealed. It then went to the circuit court in the District of Columbia. There were oral arguments in November. We are awaiting the decision. And I think that's probably a good place to stop. and sort of think then as we talk further during this webinar about what should hospitals do and how can you become ready for that. I know the other speakers have a lot of great ideas on that, but there's also a lot of unanswered questions that we'll be sharing today as well.
That's great, Beth. Thank you. And, as we have prepared for this topic, we knew that it would be a matter of time before the next new thing happened, and happened to have 2 of those yesterday. So appreciate that overview. Shannon, I want to come to you next to really talk about the hospital health system impact and how you all are thinking about and navigating what this change could bring for Grady. So I'll turn to you.
Yep, thank you very much. And hello, everyone. I'm Shannon Sale again with Grady Health System. So we've been watching, of course, 340B for years, as Beth outlined. There have been a number of, attempts or evaluations of the program from the manufacturers of how that could be shifted. And so we're always kind of aware of that. Even still, these changes were abrupt. They came for us right in the middle of our budgeting season and getting ready for next year. And so even as we were preparing for 2026, had to evaluate all of our inputs into our pharmacy budget and looking at what that financial impact was going to be, particularly as we kind of outlined here, the cash flow. And so our initial estimate is that we will have an upfront expense of $35 million that the rebate program will ideally pay back, but looking at how that happens. And so we kind of have this on 2 fronts. One is putting all the workflows in place, understanding what those numbers are, getting the right components in place, getting signed up for Beacon, making sure that we have kind of all of our ducks in a row for that. And then on the flip side, as Beth was articulating, we're kind of on board with AEH and AHA for, wait, is this really, are we really going to go down this road? We're ready, but ideally that's, something that's still a question that we're in support of, how do we reevaluate this next step that again came really pretty quickly, recognizing there had been other kind of pilots along the way, but at this magnitude and at this timing from October to the beginning of the year was a pretty quick turnaround. So we're kind of, again, on both fronts, operationally getting everything lined up to be able to comply with and be a part of the rebate program, and then looking at how do we look for a compromise or a challenge to where we are right now.
Yeah, I appreciate that. And even thinking about the upfront impact of this $35 million, how do we manage this is monumental. And for hospitals and health systems here, we'll talk in a little bit about how to start sizing that up as we approach January and things that you can do in the next 30 days even to help offset that impact a little bit. But Nicole, thinking about impact and how you and the team are leading through anticipating what that could look like, what are you seeing as teams are preparing along the way and what this impact could mean?
First, thanks everybody for joining the webinar today. And I want to start by saying it's always interesting to hear perspectives from colleagues like Beth and Shannon, because we all come at this from various angles. From our standpoint, we've spent the last many years focused on helping hospitals and health systems strategize against knowing change. Sometimes we're lucky enough that we have time to plan, and then other times we find ourselves like this, where it's like just-in-time planning to really understand what we're doing. We've spent a lot of time looking at what are the processes, what's the data and the analytics required to help set the stage for 340B resiliency. It's something that we think about within our organization, and we think about it in terms of how we support our clients. So over the last few years, we've all faced a lot of changes, whether it's around contract pharmacy restrictions, various manufacturer restrictions. And I think this is just yet another layer. And when we think about, we talked a lot about some of the policy changes or items that Beth and Shannon mentioned, but the reality is, as the 340B program has gotten bigger and bigger related to its overall value to the system, and the manufacturers continue to have a concern around diversion or duplicate discounts, I think preparing ourselves for this increased amount of transparency and visibility that they're asking for has been sort of the underpinnings, right? What is the data that they would like to have access to? How do we ensure that we can provide it? I think the part that we're spending a lot of time on now is just as the title of this webinar suggested, is how do we best manage the implications of the cash flow implications that had a lot of impact on some of the community benefit of 340B potentially. It certainly has implications on capital planning in the organizations that we work with. And so we're spending time in that space. We're also looking at building new operational processes and being able to, as best we can, in an uncertain time, what are some of the administrative costs that we'll be managing through? And I think we'll spend a lot of time talking about those today, but when you compound fronting the financial benefit in a rebate model versus the upfront discount, it creates a completely different process where this becomes almost an accounts receivable situation versus the discount. And so I look forward to talking about this more, but there's a few steps to take over the next 30 or 45 days, and I think we'll have a lot of insights to share.
Yeah, thank you. Thanks for that overview from the team. As we move into the next question, there is a constant wonder, and we've heard it many times, does this set a precedent for similar models in healthcare? And so Shannon, we'll start with you. And you talked a little bit already about anticipating the impact, but why is this going to be such a significant change? And what are the things that you're thinking about as you're leading your team through the change?
Yeah, we see this as kind of a significant change and a fundamental shift from the original intent of 340B. And this was just to kind of ground us all and a reminder of where the program originated. It was a federal program that allowed certain hospitals to have deeply discounted prices for outpatient drugs to help to improve access and to get needed drugs to the patients who might not be able to afford them otherwise. Through this program, we already have eligibility criteria, we have program requirements, and we go through really detailed audits. And so there's a lot that goes around the program as it is today, with that goal of spreading those scarce resources, scarce federal dollars, to as far as possible to make sure that we have these programs in place. Again, highly regulated, so that we are making sure that it's doing just that. I know when we go through an audit, we take it's a lot of it's a high profile time. And so looking at that and where it is and kind of the fidelity of that model, recognizing that allows us to take those resources and have programs in place like food as medicine, our food pharmacy, our medical adherence, so that we are helping to ensure patients with chronic conditions are staying on their medications, that we have a robust PrEP program for preventing HIV, that we have a drug delivery program. All of those we're able to provide to the communities that need them the most through this program. And so when we look at what is that change, when you layer on both that cash flow implication, the potential for denials, as well as increasing the administrative cost of to manage the program, some of those wraparound services, those components, or by virtue of having that funding through 340B, will start to shrink. And we'll shift that to kind of that administrative side. And so that's our biggest kind of concern, and where we see such a significant change from what the original intent of 340B was, how we were able to use it and expand that care, and how now some of that's going to likely shift to more administrative overhead to make sure that we're actually just getting paid for what we're supposed to get paid for. Mm-hmm. And the precedent that this sets is, this is a pilot, as we define, 9 or 10 of these manufacturers, and that it would grow. It's already grown from where it was a year ago, gone to this, does this grow and becomes an even bigger part? It just shifts again, fundamentally, that 340B plan, or that program, so that it really is more about how we're getting dollars back and forth for people versus being able to make sure that medications are getting those who need them the most, as well as those very important wraparound services to help to keep people healthy.
Yeah. The concept of fundamental shift, I think, has been used so often. And Beth, if you think about the work that you and America's essential hospitals are leading and the advocating that you're doing, what are you hearing from member hospitals, and how does this change impact the landscape of your membership?
Yeah, well, we're hearing widely from our members, and I think Shannon very clearly laid out the impact on Grady, but I think those same points I've heard over and over again from all of our members in just their concern about this upfront cash flow issue. Talking to a community health center, they were even looking at loans. Do they need to take out a loan in order to be able to afford that wholesale acquisition cost upfront? But our members are starting to calculate, what is their float going to be? What do they need to have just in case they don't get those rebates in a timely manner? What are the compliance costs going to be? I heard a hospital the other day say they thought it would be about another $500,000 just in compliance costs, which kind of goes back to that loose regulatory framework that HRSA has in place here, where all of the manufacturers can do something different. So it's very unfair that each manufacturer can set up one program that they then work with hospitals, but hospitals have to respond to all 9 programs that manufacturers have put in place. So I can't overstate enough the administrative burden. Beyond that, beyond the very real, tangible impact like Shannon laid out, I think this is really a fundamental shift in handing over regulation of a federal program to an industry that has a financial stake in it. It really is the proverbial fox guarding the hen house here. And it kind of lines up with the pharmaceutical manufacturer's goal of kind of killing the 340B program, line by line, sort of death by 1,000 cuts here. So, it is extremely concerning to see the program pivot in this manner.
Concerning, certainly, and I think this question and that Nicole, I'll bring to you to share thoughts and then respond to. Is it even realistic that this could be a 1-year pilot? And what are your thoughts on that?
I think that it's certainly going to depend on the success factors, whether or not the pilot stays. But I do think we all understand that rolling back a pilot at any of this size is going to be difficult. I think one of the things that's really unique and why we call this setting precedent is it's interesting that the only drugs or manufacturers that are part of the pilot are those that are part of IRA, but every covered entity that's a part of 340B is a part of the pilot, which is sort of different and apart from what most pilots are designed by. Usually you have an opt-in or there's some sort of benefit to being a part of a pilot. And in this case, that isn't the design of this pilot. And so I think it will be difficult to sort of roll that back. I think the other part is the burden of success on this program actually lies in the hands of the people that are most going to be impacted, which is the hospitals and covered entities themselves. They carry the burden of the cost, they carry the burden of the operations, they carry the burden of the reconciliation. And while there might be some benefit to the transparency and the visibility that maybe we're not all seeing right now, if I kind of put an optimistic lens, maybe there's some things we're going to learn through this. But the burden of making it successful actually relies on the individuals that have to carry the biggest part of the cost, that don't have the financial solvency to do this in the way that some other organizations do, and they have no choice. And so I think from a precedent standpoint, that's a hard thing for all of us to process through. And I think why all of us so often thought that this would look different if we went down this path. Now, that being said, we've all talked about sort of fronting the money and the cash flow, what that means, but it also starts hardwiring and starts exposing data in a way that's very different. And I think it, as Beth has called out a few times, starts really setting the oversight expectations that have been a little bit gray. And those things will have to be nailed down far more than just the pilot. I think this is where legislative changes will have to start helping frame ultimately what the future looks like. Because I think the pilot in an expanded format also is not really probably a viable program without other sort of legislative decision-making that's done. So, when we look at it, some of the numbers that we have, just to kind of compare notes to what we don't have, is that we have seen that the administrative cost could be anywhere from an FTE or two all the way to, as Beth said, over $500,000 a year. You compound that across all the participating hospitals, and it's going to cost health systems about $400 million a year in administrative cost to prove a pilot, right? And then you think about the fact that the average dish hospital is going to be floating about $72 million of cash to front the program. I think that's the real part that we're all working through, is how do we best manage that? How do we help ensure that doesn't impact the patients that it's serving? And then learn from this pilot as quickly as we can in terms of like whether or not it's sustainable and expands any further.
Thanks for that, and framing it up in numbers too, I think is certainly impactful. The next question takes that a little bit further, and Nicole, we'll stay with you to start this one, where we really start to frame up what should folks on this call be thinking about. This will have far-reaching impact, clinical, operational, and financial. And one of the questions that we hear, even without this rebate model pilot in play, when people start thinking about specialty pharmacy programs and a hospital being able to serve their patients and provide specialty pharmacy services to their patients, oftentimes folks who are getting started will say, well, is it too late, and how do we get started? Organizations who have very sophisticated and robust programs will say, how do we offset the impacts and all of the hurdles and obstacles that we're facing? And so if you could talk about this question with Clearway's view, as we think about organizations who have not yet started, are just starting a specialty pharmacy program, all the way to ones who have, very mature programs that we're supporting. Would love to hear your thoughts on what these systems should be thinking about.
Thank you. I'll start with in organizations that might be early kind of in their pharmacy sort of maturity. And I think there's a benefit here, because I think there's an opportunity to design your program with the rebates in mind, which most of the organizations won't have sort of the opportunity to do. And I think the ability to sort of set your data infrastructure that supports processes that include more of a look back and reconciliation process versus a front end. And so those are completely different, and you get to start that design and that governance really from the beginning. And you have some options related to how you choose to sequence your growth. For organizations, like Shannon's and many that are on this call, that looks very different when you're a highly established program, because you're looking at, how do I quantify my exposure, right? How do I understand what my exposure is? And in a bit of a compounding way, we've got the IRA on its own, we have the IRA and the rebate model, and we have some adjustments coming from manufacturers that is also new related to WAC reductions. And so we have to fully understand, what is my exposure as an organization for this program? And then probably one of the most difficult things to do, but one of the most important, is to start really understanding the quality of your data. Do you understand, and do you have clean NDC mappings? Do you understand and do you have clarity in some of the eligibility logic and where you might have risk related to rebates that you have, or eligibility you've had that could become questioned, because managing denials, as Beth mentioned, is a bit gray. How you looked at your accumulator rules, and when is the timing of how you intend to submit your claims? Are you going to do this daily, weekly? And how you manage and reconcile that is going to impact your cash flows as much as it's going to impact how much staff you need, right? And that's going to be based on your volume, and each individual organization may be a little different. Your other vendors also have a role. So pressure testing your vendor readiness. How ready is your TPA and your wholesalers? They're also impacted in this process. And you have to have a very tight understanding of some of those integrations, because integrations always introduce risk. We've talked on other webinars around how well TPAs are managed, have always been a risk in 340B, that will continue to be a risk in this new space. And then I think every organization should be revisiting their payer and manufacturer strategies. How are you engaging with manufacturers? How are you engaging with your payers? Are you reassessing site of care strategies? Are you talking with providers? Are there ways that therapeutic care plans are reviewed, and appropriateness? I mean, that there's a lot of things that can be done across organization, all of which have an opportunity to impact this strategy. But I think one of the things that's really important is that as you go through all of these things, like business as usual is very disruptive. So you're going to have to think about, how do you manage through these changes? How do you set your strategy, and then sort of the operational workflows around it? And then at the same time, keep functioning as, this high, very important sort of service line in the specialty pharmacy space. So those are all the areas that we're tending to learn. I mean, in each of those, we could go into some pretty deep detail, but many levers to work through, and they cross operations, finance, technology, service line, in your provider base. So I think all of those are areas that need to be sort of investigated and planned around for this program.
Nicole, thanks. It's no lack of things to help health systems prepare and make sure they're achieving readiness. That's the hospital health system side. Beth, we've had many conversations, and I've heard you say we have a very long list of questions for HRSA, because in order to help hospitals really prepare, we have to have some answers. So looking to you here for what that could mean in each of these impact areas.
Yeah, so I think, as I mentioned, I think there's a lot of facets of this pilot program that HRSA hasn't really thought through at this point in time. And while one of my chief complaints, as I mentioned, is that there's not necessarily a easy pathway for hospitals to appeal or ask questions of HRSA, I certainly think that you should be reaching out as a hospital to the agency every chance you get, to Apexis, to the prime vendor, to the folks at HRSA, whether it's through their general email box or directly to the staff in the Office of Pharmaceutical Affairs, and asking the very real questions that you have in all of these spaces, the clinical, the operational, financial. My hope is that they would put out, or will put out, further guidance, but I think, unfortunately, although it shouldn't be hospitals' responsibility to raise these issues for the first time, that's kind of where we are. So to some extent, everybody has to be their own advocate in trying to seek out answers to these questions from the agency.
Thanks, Beth. Shannon, we'll come to you next. You talked already about the work that your team is doing to really understand impact and prepare. Thoughts on these areas and where you have most concern or most hope for the impact of the pilot program?
Yes, we've certainly looking at where we go on new products, or we are in that kind of launching specialty pharmacy. Everything that we've looked at to get us here, we have to relook at from the revenues, the expenses, the cash flow, what are the workflows to do that. So Nicole said it's kind of maybe not as hard to adjust since we haven't gotten fully into it, but we do have to adjust kind of that planning part of it, with that opportunity kind of a clean slate to design the program. But then, like I said, looking at new products, do you go after a new medication that you would negotiate one way and then you're going to have to renegotiate another way, kind of figuring out kind of where we want to put those resources as we go forward, making those specific decisions kind of line item by line item. And then knowing that we need to kind of to be able to reinvest and shore up some of that staffing and the IT workflows that make sure that our data are in alignment with what's going to be needed in the future. Establishing those really robust workflows that meet, again, that future need for reporting, and being able to work through how we are making, again, those decisions on a daily basis. We have concern around, we're submitting a lot of data, and where's that data going and how will it be used? Beth articulated, I think early, the number of data points has grown. That has to be a part of this reconciliation, and how will that, how will we do that is one part of that workflow, and then how will that be used in the future, certainly keeping our eye on what that is. So working through each of those issues, again, as I say, kind of on a line by line, making sure that we have our teams in place and that we use our systems to fully implement this successfully.
Thank you for that. This is, I think, a good overview that leads us into talking about risks and mitigation strategies. And so this is where, this panel is really going to talk through, now that we've thought about areas of impact, how can we start to mitigate risk, knowing all of the work that has to happen amidst all of the unknowns. And so, Nicole, we'll start with you on any of these strategies that you can share with the group today.
A couple that, I'll call out. So I think that we talked a lot about the cash flow implications. I do think that we have to think about the fact that these cash flow implications and or revenue, keep in mind the IRA will impact revenue, rebate will impact cash flow, and then the WAC pricing will. So there's a revenue and a sort of cash flow component in this. And one of the things I haven't called out is that this then may impact dollars that are being used for like patient financial assistance programs. And so I think taking time to look through that is when we haven't managed yet, but I think there's a mitigation strategy and understanding the amount of your patients that rely on some of those dollars for their care, specifically in the pharmacy space. Also related to the cash flow, I mentioned this a bit earlier, but I do think thinking about now the pharmacy revenue from a standpoint of like treating the rebates like accounts receivable versus what had typically just been cash and related to like how you manage that. So the reconciliation, tracking expected versus actual payment, understanding when you like, there's a whole process around that there are not going to be clawbacks on rebates. So there might be things that you have to plan for that you don't really monitor today. And so I think those are a very important financial or almost a rev cycle process that we need to put together. The other piece that I would call out is that the reconciliation is going to require, typically 340B teams within the health systems are relatively small. That reconciliation process and working with your various technologies is going to have to be a bit of a command center or nerve center of sorts. And so it'll be another area that you might want to look at reinforcing some of the staffing in that space. And I think the last thing that I'll call out, and we haven't mentioned this yet, but I do think it's really important, is that the expanded data visibility can create a really great benefit for sure. But I think there should be a healthy concern that the more data that's flowing to manufacturers and beyond, and any inconsistencies create opportunities that can be interpreted as duplicate discounts, ineligible patient definitions, could be interpreted as diversion, all of which would be denied claims from a rebate standpoint, all of which now would hit margins. We've got cash flow, revenue, and margin implications. And so the best way we can do that is ensure that we've got a refresh look at our 340B compliance plans, documented policies, understanding eligibility, and being very tightly managing all the integration points, because any of those failure points that could create eligibility issues or data issues add just yet another bit of complexity. So I would say perform some mock audits on the pilot drugs. That would be a great risk mitigation strategy. And just think about the different connection points between finance, rev cycle, and pharmacy that don't exist today that you're going to want to sort of really focus on.
Thank you. Beth or Shannon, any thoughts to add here on risk and mitigation strategies?
So I can definitely share more on the risk side of this. I feel Nicole and Shannon they're the strategy folks. I'm just here to kind of tell you how bad things are. But I think some of the risks, we mentioned these a little bit, but I think a couple of other risks I want to highlight. I think there's tremendous risk with this data flow. Who knows what the manufacturers are going to do with the data? So nothing precludes them from, as far as I can tell, from using it for other reasons, whatever those might be. And are you going to be sending any protected health information? Are there any HIPAA concerns? I don't know what the Beacon system is set up to do. Maybe somebody smarter than me has thought about that already. I don't know. So those are some of the risks, I think, from the data side that I do think we need to get a better sense of from Beacon and from the manufacturers. But I also think there's a huge risk to patients here. And Shannon talked about some of this when she shared all of the things they're able to do for their community because they have those discounts and they have those savings on the 340B drugs, what they purchase, that allows them to invest in other programs. So programs such as, say, a pharmaceutical adherence program you might set up for your patients, or wraparound services to connect patients to community services like food insecurity or housing instability. I'm concerned that all of those programs that our members do because they really invest in improving their communities writ large, not just their health when they come into the four walls of the hospital, but really trying to promote health out in the community. That I think is the real risk here, is that human risk. So I'm very concerned about our hospital's ability to do all of those services that they don't really get a direct reimbursement for, if they're now more concerned about this cash flow issue and whether they're even going to get the payments back.
And I'll just reiterate the needs around workflows. I mean, that's kind of all we can do right now is prepare and to make sure that we have all of those steps, hopefully, as well as we know them, in place from a mitigation of the strategies, and building back off of Beth's point of how do we making sure that we the right partnerships in the community, or what else can we do to keep some of those wraparound services in place. But that is certainly one of our biggest risks.
Certainly. And, as Beth shared at the top of the webinar, even as recently as yesterday, America's Essential Hospitals, American Hospital Association, these groups are a voice. And so connecting back to those to know that you have resources, and using partners like Clearway Health and others to help to support staying updated and preparing for what's next. Certainly resources that you can rely on. So, Beth said, here to call out the terrible stuff and the risks, but is there a good news story here? Let's end with, is there any good news? What guidance would this team share with organizations that are on the call? There's been a lot of tips about, mock audits and preparing for FTEs and staffing and processes and technology, but what's the good news story, and what guidance would you share? Beth, we'll start with you.
Sure, you're asking me to go deep on this one, Allison. But there are a few silver linings here. I think, first of all, this rebate pilot program has really highlighted all of the good work that hospitals do with the 340B program and the discounts, getting at all of those wraparound services again, and investing in the community. I think highlighting for the public, for lawmakers and others, those are the things that are really at risk. I think there's more light that's been shed on that. And I say that because on the Hill, we had success in getting over 200 members of Congress to sign on to a letter saying that the rebate models were not what Congress intended when they set up the 340B program, that they intended it to be upfront discounts. That's a lot of members of Congress that have varying perspectives on the 340B program, if they even know what it is. So to get 200 to sign on to that letter, I think really highlights how we're able to share the visibility of the good work that hospitals are doing. And I think the final thing I would say is that, we have ultimately seen support for the program coming from this administration, from the Biden administration, and from the first Trump administration. Rebate pilot program notwithstanding, each administration has gone to bat in the court system for HRSA's ability to defend the program and regulate the program. So, knowing that we have government stewards on our side who believe in it, I think can also lend us a great voice, and to have those champions on our side.
Good. Thanks, Nicole. Let's go to you next.
I'm kind of like Beth. It's kind of hard to find sort of the good news story in all of this, but choose an optimistic point of view here. I think that a few things. One is most of 340B through this pilot remains an upfront discount. So the pilot is relatively narrow. So I think from that standpoint, gives us a chance to learn with a smaller bit of change. I think it does provide a chance, and yet a different perspective in terms of how we want to modernize a 340B infrastructure. So I think about the ways we've all tried to influence the voices in Washington and the way that 340B looks at this will yet provide, I think, some more information, because we all have known that some change is probably necessary and likely. And so how do we continue to influence that in ways that are important for the covered entities and for the patients? And then the other part of it is, I think what we're going to see more and more is like how powerful the hospital story is. Shannon's talked about it, Beth mentioned it, like it becomes more and more evident how much the safety net and disproportionate share hospitals rely on the discounts of 340B for their ability to operate. And that is a good story, and it's one that, would be difficult for us to financially support in any other sort of way. And I think, so for that reason, I think, and through all this discussion, I think we all had this moment of denial for a little while. Maybe some of us still do, thinking that maybe a court case might change something. But the reality is we do have to move into sort of this, my guidance is just to move into design, right? Let's really start problem solving. I think that if you're a hospital that's going to be greatly impacted by this and pharmacy is not at the table in your main strategy discussions or C-suite discussions, this will be a big challenge, and they need to be there soon because you'll feel it in financial ways. And I think that, join Beth and being loud and constructive and the voice that we want, that's like, we just got to continue to be represented so that we can influence where we want 340B and where we know it needs to go.
Thanks, Nicole. Shannon, your thoughts?
Yeah. So as I chatted with my team a little bit before this, they're ever the optimist around, the 340B program in and of itself is a good news story, right? It is one in which we're able to get additional funding to do the things we've talked about before. And so being able to continue a form of the program is a good news story. And, having our strategy in place and having the right, as I've talked about, workflows, it should still be there, and they're very positive about that. I'll kind of build off of what Nicole said as well. Moving pharmacy to a role within the strategy. Over the years, our pharmacists, of course, have become key members of our clinical teams. They're tied to our population health strategies and how we manage chronic conditions, and then also obviously tied to this very important program. And so ensuring that the pharmacy team has a good, strong strategic plan, and that plan is woven within the organization's plan. I think times like this really do tie together the relationships between pharmacy and finance and RevCycle and IT to make sure that is solid. And so working towards those interrelationships, that strategic plan, kind of the level of focus that we've put around the pharmacy and the integration within our key clinical teams is an ongoing good news story that we'll continue to pursue.
That's great. I appreciate choosing optimism at the end of a rather dismal conversation, but I think it's important to send folks off with actionable things and to know that there is hope. There have been a lot of questions. If you have any, please add them in the Q&A box. There are several that we'll work through now. And I want to start, Beth, with you. You mentioned this at the top of the webinar, and there was a question that came in specifically about the lawsuit from yesterday from America's Hospital Association and the state of Maine and 4 other hospitals. The question is, do you think this lawsuit will help slow down the rebate model? But tell us a little bit about the lawsuit and then your perspective on it.
Sure. So the lawsuit specifically asks for a temporary restraining order. So it's asking the court to prevent the initial implementation on January 1 of the rebate pilot. I assume, and I'm not part of the litigation, that they would want the judge to eventually rule on the merits of can HRSA do this or not, and those other court cases are also ongoing at the same time. So I can't guess what would be in a judge's mind as they're reviewing this, but the temporary restraining order by its nature would be taking effect, if they secure it, taking effect before January 1. So on that initial question of can this move forward on January 1 or not, we will know the answer to that question, hopefully, I would expect, prior to January 1, but that doesn't really solve kind of the overall legal questions around the program. Also, I would note that if you want to get something done quickly, the legal system is not your vehicle. So we've seen that time and again. We were party to a couple of lawsuits on 340B policy issues. These things do take years to come to final resolution. So we are not going to know the final answer according to the courts on the legality or not illegality of the rebate pilot program for a long time, but we should know more clarity about can that January 1 implementation date move forward or not, presumably before January 1st.
Good, thanks. There have been a couple of questions about drug price. So Nicole, I'm going to come to you with this one. Some are very state specific and some are more general. So the way that I'll frame this up is, does the pilot program allow for price changes between WAC or wholesale acquisition cost and 340B pricing in addition to the upfront cash flow process? Will you share thoughts and insights on that?
Yeah, so the pilot itself doesn't have a design mechanism or an incentive to change the wholesale acquisition cost, or the WAC cost. It also doesn't preclude manufacturers for changing their pricing strategies. And so if the manufacturers continue to manage their pricing strategies, which would essentially show up in WAC, then they could change their WAC pricing, and that in effect would impact this program as well. There have been some manufacturers that have sent notices to organizations of that change. And it does not change the 340B ceiling price or the MFP of which that they're obligated to pay the rebate compared to. So they're not incentivized to do it. They're not required to do it. There's not a mechanism in the pilot to suggest they should do that or shouldn't. It's something that's in their control and pricing strategies.
Thanks. Beth, I'll come back to you for this next question. It did make me smile. It's really asking, is HRSA even ready for this? And so based on your experience and thinking about people power, structure, and their readiness, is HRSA prepared to take on the start of this program?
Well, I think the team in the Office of Pharmacy Affairs, they're really dedicated. They are small but mighty, and they really defend the program and believe in the program. That said, I think that this pilot, particularly with different plans coming in from each manufacturer, is probably a lot for them to take on. They are not the most heavily staffed group in HRSA. And so I think that this is going to be a lot for them. And I think they're probably under-resourced compared to, what would be optimal to take on some of these regulatory challenges.
Thank you. That is the questions that we see here. I'm sure there are many more, and there are certainly some that we may not even have the answers to yet. But as we wrap up today, would encourage you to rely on your peers, rely on advocacy resources through America's Essential Hospitals and others, and certainly know that Clearway Health is here as an eager resource to support you all as you go through navigating these changes. But most of all, thank you for your time today. We appreciate you spending your hour with us. Please reach out if we can support you, and have a great afternoon. Take care.